Hi, everyone. Welcome to the Gut Reset Summit. I'm your host, Dr. John Dempster, and today I am joined by Dr. Ilana Gurevich. Dr. Gurevich is a naturopathic physician and acupuncturist, and she graduated from the National University of Natural Medicine with a doctorate in naturopathic medicine and a master's in Oriental medicine. And she is currently co-owner of two large integrative medical clinics in Portland, Oregon, and runs a busy private practice specializing in the treatment of inflammatory bowel disease, as well as IBS, SIBO, and other functional GI disorders. And Dr. Gurevich lectures extensively and teaches about both conventional and natural treatments for gastrointestinal conditions. And she's one of the foremost experts on the intersection of IBD and IBS and how treating one resolves the other. And she also acts as a mentor in the naturopathic community, and she supervises residents and consulting with physicians about GI disorders and their most difficult cases. So, Dr. Gurevich, welcome to the Gut Reset Summit.
Thank you so much for having me. I'm excited to talk.
Well, I'm excited to interview you because you are an expert in so many things gut related. But as I usually start these interviews, I want to know, what is your story? How did you get into being such an expert in the gut space?
So I come from a long line of physicians. My grandparents were physicians. My parents are physicians. And when I was growing up, I was going to be anything except a physician. And at the age of 12, I started having GI symptoms. I went to 5 or 6 different gastroenterologists. By the age of 19, I was excessively sick. I was 85 pounds, my normal height. I couldn't put on weight. I was chronically fatigued. I was in chronic pain. And I finally had a gastroenterologist actually perform a colonoscopy, which is the first time they'd done that in my 7-year history. And they discovered I had moderate Crohn's disease. And I was hospitalized. I was started on steroids. Back then, we did not have a lot of treatment options. It's not now. I was started on a very high dose of steroids. And I was lucky enough in some ways, because at the time, my father, who's a psychiatrist, was going through his midlife crisis. And while most men go through a midlife crisis and they buy a car or have an affair, my dad was discovering alternative medicine. And so through a series of events, he decided to get his acupuncture license on top of his medical doctorate. And he met somebody who was a naturopath, and they put me on the road to meeting with my first ever naturopath. And, I was 19 years old. I was on 60 milligrams of steroids. And anybody who's ever taken steroids know it's a crapshoot if the disease is worse or the steroids is worse. I had every side effect. I was manic because it was a very high dose. And the naturopath said, his name was Dr. Sensening. He's since passed away, but he was basically like, do what I say for a year. Give me 1 year of doing what I say, and I promise you'll be healthier. And I can remember a year later, I was living abroad. I was living in Scotland. I was a normal weight. I had energy. I was, Scottish culture is very surrounded by partying and drinking, and I was able to fully participate in life. And there was this moment where I actually ended up getting on the phone with one of my housemates' friends who was a Crohn's patient. And he had been on an elemental diet for, I think, 6 months, liquid only diet. He was dying, and it gave me this huge juxtaposition of, oh, that was me a year ago. A year ago, I was dying. And, over the course of a year of really not even complicated interventions through the naturopathic guidance, I was like alive for the first time since my early childhood. And that set me on a path to, put myself on my healing path and become a physician myself. And, I have not regretted it at all. Every day I'm in clinical practice, it is an honor to get to sit with the patients that I get to sit with and offer them the guidance and the support. And sometimes, just the presence of hearing them and helping them regain their own health path.
What a story. Wow. Thank you for sharing that. That's super powerful. We're going to talk a lot about a number of aspects today of IBD, IBS, and so forth, but we're going to really dive into this topic of biofilms. And I know, again, you're going to share some powerful insights. So tell us a little bit about what they are, and then we can dive into how they're related to gut issues.
So I think when we talk about biofilms, we have to start at the beginning. And the beginning is like the beginning. So we think that bacteria has been on the earth for roughly 2 trillion years. Humans in their human form have been on the earth for about 200,000 years. So we have to begin the conversation with the understanding that bacteria is older, bacteria is smarter, bacteria has more resilient skills, and they reproduce significantly faster than us. And they make environments that are more hospitable to them oftentimes than they are with us. They also make environments where they cohabitate with us. And actually, it is the bacteria that allows us to, do the majority or a lot of our functions. We have 10 times as much bacterial DNA than we have our own DNA. So the story really starts with bacteria. Back in the 1980s, we were starting to see this patterning of infections that were difficult to treat. And we couldn't understand why. And I think when I did my last data search in like 1982, there was like 2 papers written on biofilms. And like the next year, there's maybe like 4 papers written on biofilms. And if you look, I think I just did a search last month and there was 8,500 papers written on biofilms this year, right? So we know that antibiotic resistance is being caused partially by biofilms. And what those biofilms do is they give bacteria the opportunity to become immune to many of our treatments, especially our pharmaceutical treatments. In the 1950s or 40s, when we first started using antibiotics, they were kind of amazing. Like they killed everything and you had an acute infection that was healed like that. And so, we stopped looking at other options besides antibiotics to treat infections. Fast forward now, what we have infections that are more and more and more resistant to our antibiotics. We have pharmaceutical companies that are less incentivized to discover new antibiotics. And we have more immune resistance so that treatments are, longer, more harsh with more side effects and less effective. We are actually in an arms race with bacteria and we are losing.
Yeah, full stop. I couldn't agree more. Now, what consists of a biofilm? What is it made of? You've got the bacteria, and what else?
So I don't want to, the first thing to know is it's not just bacterial, it's viral, it's parasites, it's protozoa, it's viruses, it's phages. They're all cohabitating together. The best way I can describe it is like, I'm from New York. I grew up in New York. And in New York, we have these buildings and you see the people coming in and out of the buildings, right? But you also know that there are mice there and there are cockroaches there and there are rats there. And so they're like these really, really diverse environments or communities. What happens is that when bacteria or other fungi, parasites, protozoa, they all get together. So let me back up. Bacteria has this really interesting ability to either be a single-celled organism. So that's when it's a single-celled organism, we call that a planktonic bacteria. It's one little guy doing its own thing. And oftentimes when we're running a swab on an infection, what we're finding is our planktonic bacteria. You have a urinary tract infection, they're going to collect a urinalysis and they're going to find E. coli, right? E. coli is the E. coli that's free floating. So that's causing a problem. But usually bacteria are actually not in this single-celled organism. Bacteria actually has the ability to come together and to make a community decision to start to build a city. And when the bacteria comes together and builds a city, all of a sudden, this single-celled organism now becomes a very large multicellular organism, right? The bacteria come together with a virus, with a fungus, and they hyper-specialize into different roles, and they build walls, similar to the way that we build buildings. If it's blizzarding where we are, we don't really care because we're inside of our walls. Bacteria is doing the same thing. They're building walls to protect themselves from the environment of our mouth, our bladder, our GI tract. And when I'm trying to describe to patients what is a biofilm, plaque on your teeth, you go to the hygienist, she scrapes your teeth. Now you've got airflow through your teeth. And then 3 weeks later, it's there because the bacteria has rebuilt the walls around themselves to protect themselves from the elements of your mouth.
Right.
That protects them because when we put an antibiotic in our bodies, that wall that they're building isn't really going to matter because they're protected. When we put enzymes, that's not going to touch them. They become resistant because the antibiotics are touching everything that's on the surface, or all the planktonic guys, but it's not getting into the biofilm. That's really why antibiotics are also not working. And then bacteria have the ability, when they're in their cities, when they're in their biofilm communities, to share DNA. And so if a planktonic bacteria lives through an antibiotic attack, it goes back to its biofilm community and now it has resistance. It knows how to fight that antibiotic to make it not work. And so then it shares that with all the different antibiotics. All the different bacteria.
Crazy. So not only are these things becoming, resistant to our treatments, are they creating also like an actual physiological problem with
Oh,
their presence?
oh yeah. Oh yeah. They are full on building walls. Yes, absolutely. And the GI, the vagina, the bladder, when we are thinking in our, as a clinician, one of the things that always targets my thinking to it's a biofilm issue is a chronic disorder, chronic vulvovaginal disorders, chronic GI disorders, chronic otitis media in the ear. That's a biofilm issue. All of these chronic conditions that we can't wipe out with a one and done, we want to start thinking about biofilms. And the more chronic, the more we're worried about biofilms.
And so I guess, my first question is like, how do we know if we have them? Do we just assume that if we have a chronic condition that that's what it is? Or are there ways that we can test? Can we measure these in labs?
So I'm primarily GI focused. That's almost what I do. That's almost all I do. And so I'll run stool analyses.
Hmm.
When I'm running stool analysis, I am a big fan of what I call provocation. Provocation means I'm trying to give them something to break down the biofilm in a not very aggressive way before I collect their stool. And then we know that there are certain species that are just notorious for creating biofilms. Pseudomonas. Pseudomonas is always my bad guy. If you Google Pseudomonas infections, like especially post-surgical Pseudomonas infections, what you'll find is the Pseudomonas will excrete this thick, yellow, hard plaque. That basically is the perfect wall to protect it from the elements of your body, right? So if I find Pseudomonas, I'm always going to go after it. Other infections that we know harbor biofilms are like Klebsiella is another one. Staph and strep can sometimes harbor biofilms. It's like they're not necessarily bad guys, but they definitely could be bad guys in the right environment. Prevotella is known to harbor biofilms. Proteus is known to harbor biofilms. And that's just the GI. We can move to the vagina. Candida, we know affects biofilms in the vagina. Gardnerella or chronic BV. And then, otitis infections.
So basically, if you run, again, we don't have labs to run all of these, but if you run a good solid GI panel, and fortunately, there's some fantastic labs that do these, and you see any of those species, it's safe to assume that, hey, we got biofilms, we got to get after it.
I mean, and I feel like it's important to also have that chronic history.
Yeah.
So,
Yeah.
like, it's not always a problem, but if it's been going on and you've been trying to kill it for a long time and you've thrown everything at it and it's not going away, assume that the reason it's not going away is because what you're throwing at it isn't getting to where it's supposed to go.
So what do we do? How do we get rid of these stubborn biofilms?
I think it depends on what species you find and how stubborn it is.
Hmm.
I will say that I don't know, maybe 5 years ago now, Dr. Paul Anderson, who is one of our naturopathic mentors, started lecturing pretty exclusively about biofilms. And he came up with a great formulation using bismuth subnitrate and alpha lipoic acid and a chelator. It was DMPS and now it's DMSA. I find a lot of use with that product. Right. So I compound it up. I'll put patients on it on a pretty large protocol. And then I'll introduce other things like herbal antimicrobials. And, you just kind of do a literature search. You find what the data shows about what antimicrobial is effective for what infection. You kind of take a good history. And so then you worry about trying to address what's underneath the biofilm. And then you always worry about how do you rebuild, and that if you're just killing, then it's not going to lead you anywhere. You need to kill, but you also need to rebuild. And you rebuild with high quality food and a high quality diet and fermented food within the diet and a diverse diet and, exercise and lifestyle factors and just kind of rebuild our GI to help us be a human again.
Are there any dietary or lifestyle triggers or aggravators, might be a better word, that can really increase the tendency towards biofilms that we should be looking out for?
It's interesting because within the last 5 years, and I mean, we've known it longer, but it's really been solidified in the literature within the last 5 years, that a lot of our antibiotic resistance is being caused by bacteria that we're giving our food, right? Like, so they think one of the most significant reasons why at the moment we have antibiotic resistant E. coli for urinary tract infections is because we were giving chickens a bunch of antibiotics in their feed, and that taught the bacteria to be resistant to the antibiotics. And then we eat that chicken and it bioaccumulates within us. And now we've got a more resistant strain of E. coli. That's not because of something we did as humans. It's because of one of the ways we dealt with our food industry. And so we see that again and again and again. So in my experience, food has to be the foundation of anything that we do. And, it's important to know that as far as food goes, up until 100 years ago, there was not a single culture on the planet that didn't use fermentation as a preservation technique, right? So, like none. That was the way we preserved our food before 100 years ago, and we introduced refrigeration. We preserved it with fermentation. And we had significantly less GI issues and autoimmune diseases and cancers and heart diseases and all of the other diseases of the Western lifestyle, just because we were introducing a variety of bacteria within our body. It's important to know that when we're talking about biofilms, not all biofilms are pathogenic. In fact, our large intestine, if it's never been treated with preservatives or antibiotics or pesticides or herbicides, there's a biofilm happening in the large intestine, but that is a sustainable biofilm. To make something from sustainable to pathologic, what you have is bacteria that's eating up the resources before the body can replenish it. Like, I'm pretty convinced humans are a biofilm on the earth. We're utilizing our resources in a way that's faster than the earth can replenish it. Same is happening in our body with the pathologic biofilms.
Got it. Any other dietary keynote strategies that we've got to pay attention to when we're dealing with these? We got the fermentation. We want to do that.
I would avoid as much as you can pesticides, herbicides, preservatives, ultra processed food, even processed food. It's like all the stuff that's just low hanging fruit. Eat a whole foods diet, make sure it's clean, make it be diverse. Don't eat the same 5 things again and again. Different food provides different nutrition to us and our bacteria. And so you just want to be introducing a variety of different things into your diet.
Great. Are there any other confounding variables that, we hear a lot about molds these days? We hear a lot about heavy metals. We hear a lot about Lyme. Is there any other conditions that could increase the precipitation or the creation of these biofilms?
Every single thing you talked about. So, Lyme is important because we know that the spirochetes are like a lot of what went on to become the biofilm research actually stemmed from old docs who were treating Lyme disease. Mm-hmm. And so that's important because we know that Lyme is, we have docs who have been treating it for, 20 years, 30 years, 40 years. So that's definitely a problem. Fungus is another problem. So, 80% of fungal infections within the GI tract, we think are candida in nature, not 100%, but 80%. We're starting to figure out that, while Candida albicans is obnoxious and hard to address, there are significantly more pathologic forms of Candida species that are more antifungal resistance. And there is definitely an upsurge in antifungal resistance being caused by overutilizing antifungal medications. And so fungus, when I think about the role that fungus plays, in the woods, there's the trees and the trees have roots, but there seems to be like one species of fungus that is all over the floor of the forest. And then, a mushroom pops up here and a mushroom pops up there and a mushroom pops up here, but it's all the same species. And they think that's like the communication pathway that the forest, that's how the trees communicate with each other. And that's how the plants of the forest communicate with each other. It's like a nerve bed within the forest. Fungus does that in our body too. It is everywhere. But if you weigh down one side over the other, then fungus can get out of control. And then it can secrete its own biofilms or work in harmony with other species to make worse biofilms.
So when we're clearing out these biofilms, when we're eradicating them, are there any signs and symptoms that we might be moving too quick? Is there any tells that we might be overloading our system too quick on a detoxification side of things? We hear this thing called the Herxheimer effect. Is that something that's applicable to biofilm?
Yes. If you're using Paul Anderson's protocol, if you have a worsening of symptoms, you actually increase the amount of the protocol that you're taking for a couple of days because the bismuth is a binder and the DMSA is a chelator, so it'll kind of break things down. And I think the most important thing that patients need to know is this is not a one and done. It is a long-term protocol. Mm-hmm. Like we are like for all intents and purposes, rebuilding your microbiome, rebuilding your GI tract. And so because of that, minimum 3 months, maximum a year.
Right. Well, so many people listening to this right now, they're dealing with gut issues directly. Are there any sort of highlighted gut conditions that you've seen that are almost always, again, affiliated with different types of biofilm issues?
It's always chronicity. Honestly, it's always chronicity. I'm not going to look for a biofilm infection if it's something new. You know what I mean? Like, I don't think that's a biofilm issue. I think that's an acute gastroenteritis or that's an acute gastritis. Like, that's not what we're talking about here. We're talking about people who have been sick for years. They can't get themselves to be better. They've done all of the things. They've done all of the pharmaceutical things. They've done all of the naturopathic things. They've done all of the things and they're still stuck. That's the population you're working with. The ones who should be better, but still only have 5 foods that they can eat.
Yeah, no, absolutely. They get close to what we call the air and water diet, which is not fun for anyone unless it's a short term.
Or sustainable.
No, not at all. Now, I just wanted you gave us so much information earlier that I wanted to get a little bit more specific on some of those herbal antimicrobials that you're using to break up this biofilm. Do you have a short list of some of your favorites?
Yes and no. My favorites, I spend a lot of time in the literature. I spend a lot of time looking at if I can find any in vivo human data. That is always going to point me in that direction. If not, I'll look at animal data and I'll look at in vitro data. It kind of depends on the bug that comes up. So ones that come up a lot in the literature are turmeric, are garlic, are uva ursi or bearberry, are there's one more. Artemisia or wormwood. Yep. But here's the problem, and this is the main problem. There is something that happens in research where if you have a hot button herb that has data coming out on it, you are significantly more likely to get funding for your data if you study that hot button herb, right? So do I think that the data is going to answer these questions, or do I think that the data is giving me what they're more likely to get funded to study? Yeah, I think it's a little bit of both of them. And so the other thing that I'm always thinking about is, what have our Ayurvedic forefathers done? What have our Chinese medicine ancestors done? And, you look at their patterning, or what are the Lyme docs? What did the Lyme docs do long before they had data? And you kind of utilize those herbs as well. And you also look at the patient's history and see what they've tried, what's worked, what hasn't, and you throw some spaghetti against the wall and you see if it sticks.
Yeah, and we have to feed off of those forefathers. And, they were pioneers in so many ways, and they've really paved the road for us. So it's absolutely massive what we've learned from them. Now, what other areas that we haven't touched on with biofilms that you feel are critical, if any?
So outside of the GI tract, recurrent vulvovaginal disorders. That is one that is definitively biofilms, like recurrent candida infections, recurrent Gardnerella, recurrent BV, urea plasma, any the GI, the vagina, the mouth, they're warm, they're moist, they're wet. That's how biofilms, they need that they need a rigid surface in a moist environment to attach and build themselves. And so whenever you're dealing with recurrent infections there, that's important. The other place where you want to think about it is chronic long-term diseases, like with Crohn's disease and ulcerative colitis. The data is very clear for ulcerative colitis, very, very clear that we think a lot of the microbiome dysfunction that's happening with ulcerative colitis is a biofilm issue, right? The microbiome has changed so drastically in an area where there's so many bacteria and funguses and viruses that we definitely think that part of the chronicity of ulcerative colitis is the biofilm. And again, I talked about how with biofilms, what makes them pathologic is the bugs are eating up more than the body can produce, right? That's exactly what happens with ulcerative colitis. What happens with ulcerative colitis is there's, if everything was optimal, you would have this layer, like I always think like dirt, that's like that's the colonocytes. Those are the cells that make up your GI tract. And then you put a foundation down, and that foundation separates the dirt from your floor, right? That foundation in the large intestine is made by mucin. Mucin or mucus The large intestine has two layers of it because there's so many bacteria. So we've got a thick foundation to separate the bacteria, which is like where the house is, to separate the bacteria from you. And so that mucin environment is chock full of like carbohydrates and proteins and fats. You know what I mean? Like it is like prime food for the bacteria. If the cells of the large intestine can function naturally and regenerate that mucin layer, then the bacteria has lots to eat and there's still this good separation. What happens in a condition with like ulcerative colitis is you get a microbial change, and then that bacteria is overeating that mucin faster than the body can replace it. And then the bacteria all of a sudden is touching you. You've got a huge crack in your foundation. And so then you get ulcers, you get inflammation, you can get, scarring. And that's when things go bad. So like ulcerative colitis is exceptionally well documented to be biofilm condition, or at least a biofilm nature is part of it. The data on Crohn's at the moment is not as good. I suspect that as we continue to research it, we will continue to see there is more of a biofilm component to Crohn's disease as well.
Powerful. Are you seeing any evidence that therapies such as colonics or even FMT are these things that might be beneficial in treating biofilm?
I happen to be anti-colonics unless it's a one and done and things are really bad. FMT, I am pro FMT. FMT, depending on what data you look at, for ulcerative colitis in particular, it's somewhere between 60% effective and curative. There's a lot of data about it now. There's going to be even more data because now we have pharmaceutical companies that now own FMT. So I'm sure the data is going to come dripping or, flooding out in a second. But yes, I think reestablishing a healthy, diverse microbiome is very effective for changing the bacteria. And, what makes a healthy GI tract is just a lot of diversity. And so when you introduce a diverse microbiome from somebody else who's healthy and who's screened and who's not carrying pathogens, it can be a game changer. And I have patients in my practice who we literally cured their ulcerative colitis just with FMT.
Amazing. Yeah. And that's fantastic. Thank you for sharing that. FMT, for everyone listening, is fecal microbial transplants. And there'll be more information later on the summit about that. But one other thing I wanted to ask you about is what are the connections between stress and biofilm? Is there anything going on there? We know that chronic stress or even acute trauma can change the microbiome within 24 hours. Anything that you can comment on there?
Yeah, let's go really high. Let's start with really high. So we have a nervous system, right? We have, when the nerves are in your brain or spinal cord, that's the central nervous system. Those nerves leave. As soon as they leave on the outside of the spine, that's the peripheral nervous system. And then that peripheral nervous system will, bifurcate even more and end up with something that we call the enteric nervous system. The enteric nervous system is the nervous system that just controls your GI. It is crazy. If you want to take a deep dive into the craziness of the human body, the enteric nervous system, where you want to start, because for one, 90% of the nerves, let me back up. The nervous system, it's like a loop, from brain, spinal cord, out to the organs, to the skin, back to the organs, back to the CNS. It's always making this loop. The enteric nervous system is also part of that loop. But what we see is that 90% of the nerves in the GI travel from the GI to the brain, and only 10% of the nerves travel from the brain to the GI, right? So the stress that we have, the stress that we feel, we might feel up here, but really we're feeling in our GI. And that's important because when that stress is feeling in our GI, what we're doing is we're shutting down digestion. So the literature is clear. When you are dealing with a chronic situation of stress, like, I don't know, anybody who lives in the Western world and has a job, anybody who watches the news or social media, that nervous system is shutting down normal physiologic function of your GI glands, and that's causing an issue with symptoms.
Anyone who's lived through a global pandemic in the last 3 years?
Oh, I heard about that.
So yeah, once again, this is that whole person analogy, that functional medicine. So this is what we do, right? We take a step back, we look at all those areas of imbalance. So whether it's treating these with antimicrobials, working on our stress levels, clearing up any other dysbiotic organisms in our gut, we've got to make sure that we come at this perfect storm any way we can. any other areas of that perfect storm that we're missing to treat biofilms?
Well, what I think we're missing is, uh, where stress shuts it down. I do think mindfulness and meditation turns it off.
Right.
This great study that was published maybe last year, sometime in the Journal of Psychology, where it was a huge study, actually. It was I want to say 430 patient study, which in the psychology world is a huge study. And what they did is they introduced the patients, they split them into two groups, and they either gave them escitalopram, which is a standard first line therapy, anti-anxiety, antidepressant, or they introduced them to mindfulness-based stress reduction, which, when I took it, it was like a smorgasbord of mindfulness activities that you kind of get exposed to. And they had them do questionnaires beforehand, and then they introduced them to this intervention, and then they followed them up 10 weeks after the intervention. It was 8 weeks long. And what they found is that subjective response to stress and subjective anxiety was limited equally between the antidepressant and the meditation group. And so while the stress response shuts us down, the mindfulness exercise turns us back on. It makes us human. And with that comes the downriver effect of improving our microbiome and improving our nervous response and improving the health and quality of our immune system. We went to school at the same time. And when I was in school, it was always the same thing. It's not the bug, it's the terrain. Yep. You know what I mean? Like, we're not going after bacteria. We will lose that race. They are smarter. They've been here longer. What we need is our terrain to be compatible with living a human life. And our modern culture makes that difficult. But these old practices help us bring that back.
Amazing. Do you have any one particular technique that you love for mindfulness?
Yes, I am a big believer that they are all completely equal. That's what works for you. I had a patient with me yesterday, and she was like, but my therapist said to do the X, Y, and Z, and I don't want to do X, Y, and Z. I want to do A, B, and C. And I was like, it's all the same way of talking to the universe. Just sit down. Just be there.
Just do it.
Just do it.
It's progress, not perfection.
Totally.
Well,
and I'll tell you what, when we're trying to follow somebody else's script, it's never going to work for us.
Right.
You know what I mean? Like, you are building a relationship with yourself and, your higher source and the universe. It's not about somebody else's way of doing it. If you can sit and that brings you into yourself, that's how you do it.
Amazing. Well, Dr. Ilana, thank you. This has been extremely informative and eye-opening. I think a lot of people, biofilms might be a new concept, but it's definitely one that we have to consider. And so I want to thank you so much for your wisdom today. Where can we learn more about you online?
So you can find me at openwellnesspdx.com. That's my new website. Hopefully it's launched by the time you find this. And then I also have a podcast. If you're interested in functional GI disorders and how we treat, I teamed up with two other doctors, and we have a podcast called The Turd Nerds. And so you're looking to kind of hear how doctors talk through cases and what we're looking at from, chronic GI treatments. That is a great resource.
Well, you're never going to forget that. The Turd Nerds.
I hope not.
Thank you so much, Dr. Ilana. I really appreciate it.
Thank you so much. I really appreciate you having me.
You're very welcome. All the very best.